And good evening, everyone. I'm Dr. Max Gomez. I am the senior medical correspondent for CBS 2 here in New York. And it is again my pleasure to be moderating the next in our ongoing series of webinars for Columbia University Medical Center and the New-York-Presbyterian Morgan Stanley Children's Hospital. And as you may already know, tonight's topic is a especially troubling one for parents and children alike, but one in which much progress has been made. And that's what we'll be discussing in the next hour. Now, before we get to our panelists, a few small housekeeping details. Now, should you have a question, you may ask it via the Q&A tab at the bottom of your screen, and we will do our best to answer that during the webinar. There'll also be what the military calls an after-action statement or document that will summarize the key points from tonight's discussion, and it'll be distributed to all of those who have registered. And finally, a recording of tonight's webinar will also be available on Columbia's YouTube channel, and that is Columbia Children's Health on YouTube. So without any further ado, to introduce our panelists, let's turn to Dr. Cheatham, did I get it right? Dr. Cheatham Achman, the Chief of the Division of Child Neurology and the Director of the Pediatric Epilepsy Program. Cheatham, go ahead, please.
Good evening, everyone. Thank you for joining us tonight. We are going to talk about the pediatric epilepsy, and this is a great pleasure to introduce the panelists to you to discuss the pediatric epilepsy tonight. I am Cheatham Achman. I'm Chief of Child Neurology and Director of Pediatric Epilepsy. I have been treating children with epilepsy probably close to 20 years now. And this is so dear to our heart, as Max mentioned, that this is a difficult journey for parents and certainly caregivers and treating physicians. And tonight, we are going to take this journey starting from the diagnosis, involving treatments, advances in the field, last but not least, the surgical options. Now, there are advances in the field, how to approach and what type of surgery will be more beneficial and what are the advances in the surgical field. So I will, we have a panelist, and I will introduce my colleague, dear colleague, Dr. Danielle Mcbrian. She is the Assistant Professor of Pediatric Neurology and Pediatric Epilepsy. She is the Director of Ambulatory Epilepsy and Child Neurology clinics for our residency program. She is a Director of the Pediatric Epilepsy Monitoring Unit, and also she is a Director of Ketogenic Diet program, which is an important treatment options and alternative treatment options for children who has intractable drug-resistant epilepsy. And then the second panelist is Dr. Tristan Sands. He is a physician scientist, assistant professor of neurology and pediatrics. He's a pediatric neurologist and epileptologist, and his special interest in epilepsy genetics. And he is working to find pathophysiology of the certain epilepsy syndromes affecting young children, infants, and trying to find novel treatment options. And Dr. Caitlin Hoffman is the Director of Pediatric Epilepsy Surgery. She has a role in the two institutions, Cornell University and also Columbia University Irving Medical Center. She is one of the pediatric neurosurgeons, and she's taking care of giving the options, the surgical options and treatment options to our patients diagnosed with drug-resistant epilepsy.
Great, thank you. And before we get started, I have asked our panelists for their permission to address them by their first names. That is not being disrespectful. We just want to make this a little less formal and conversational this evening. Thank you, Cheatham. Let's start with, well, as the director, let me start with you and ask a little bit. Tell me about the diagnosis of epilepsy, because I think many people think, well, you have a seizure, you have epilepsy, but it's not as simple as that, and there are multiple types, right?
That's right. So diagnosis of seizures in children is challenging because in children, seizures may present with the different clinical manifestations, and often they are deemed to be not seizures. And it's sometimes not only for caregivers, but also for the physicians. It might be very challenging and difficult to make the diagnosis. So always that we look at the details in the clinical history and what type of behavioral changes that the parents observing and whether they are similar to each other, whether they occur at the same time of the day or randomly occurring. What happens to the child at the time of the events, whether change in the mental status or any change in behavior. Those clinical features may lead us to think about the seizures, or alternatively, maybe non-seizure conditions or non-seizure events. And then from that point on, of course, that with the examination findings and other details in the history, we move to the diagnostic testing, which will be important element to make the diagnosis, although not the only one, because often that even the initial diagnostic testing may not really help us to confirm the diagnosis of a seizure, or in the case that if there are repeated unprovoked events, the diagnosis of epilepsy in children.
Mm-hmm. So Danielle, it sounds like a lot of this has to do with sort of observational clinical sorts of things, but then there's to nail it down, if you will, often you bring a child in for this video EEG monitoring to really pin down the diagnosis?
Correct. We are very fortunate to have epilepsy monitoring units where we can simultaneously record video and EEG, both between events and hopefully to capture events, depending on how often they happen. As important as relying on the history is, and it is so important to, pick apart what families tell you. They often, will come in using medical terminology saying my child's having absence seizures, meaning their child is just staring, or they're having petit mal seizures, which is sort of an out-of-date term. But I've had families use it from everything from syncope to GTCs where people convulse. So, it's really important to get the history, but, our gold standard then becomes the video EEG in many cases. And as Chia mentioned, not all seizures will have recordable activity on the scalp. If the seizure is starting from an area deep or only involving a very small but eloquent area of the brain, we may not see anything on scalp EEG recording, but generally being able to at least identify what state the patient was in wake or sleep, as well as what actually happens during the seizure, as opposed to a secondhand retelling by the parent, is almost always convincing in us, settling on whether or not this is a diagnosis of seizure, and in the case of repeated unprovoked seizures, epilepsy, or something other than seizure. So yes.
And I know that you guys are very shy and soft-spoken, but if you could either speak up a little bit so we can hear you a little better, or move a little closer to your microphone, will be helpful. Tristan, there are different kinds of epilepsy, as we mentioned. Tell us just a little bit about, some are genetic, some have to do with trauma, some are after fever. What triggers these things, particularly in children?
Yeah, so epilepsy can be caused by many different things. And for some patients, we can identify a genetic difference that more or less accounts for why they have epilepsy. And for epilepsy in which the seizures start during the first 3 years of life, that accounts for up to 40% of cases. In newborns, it's even higher. In some studies, as high as 80%. Rarely that kind of genetic change can be inherited in families, but more often actually it's a new genetic change. And the seizures are accompanied by additional problems, developmental delay, intellectual disability, autism. And there are over 80 such genes that can cause epilepsy. And individually they're rare, but taken together in aggregate, they account for a substantial number of these early onset epilepsy cases. But as you were sort of saying, that's just one of several different causes for epilepsy. For some patients, we can't identify a single genetic difference when we look at their blood. And that doesn't necessarily mean that they don't have a genetic difference accounting for their epilepsy. It might actually be that that genetic difference affects just part of their brain. And sometimes we can see a difference when we look at the brain on imaging, and sometimes we can't see a difference there. Mm-hmm. And then there are other people, many people actually with epilepsy, where it's not simply one genetic difference. It's probably a contribution from a lot of small differences in genes, something called polygenic risk. And then finally, there are people who have epilepsy due to prior brain injury. And their major risk factor for developing seizures is that brain injury and a process called epileptogenesis, whereby somehow the way that the brain heals itself results in a hyperexcitable epileptic state. But even in that kind of epilepsy, we know that there's evidence for a genetic influence. So
it's not unlike many other diseases that there may be a genetic predisposition that requires some sort of a trigger to get that started?
Yeah, or vice versa, yeah.
And the other thing is, it's not, well, actually, let me ask Caitlin this, because this may or may not fall exactly in your bailiwick there, but I think it's not just one seizure that defines you as having epilepsy. What actually defines someone then who has epilepsy? What does it take?
Yeah, I mean, typically, and of course, this is within the purview of my colleagues here, but one isolated seizure that is either triggered by a known cause doesn't automatically identify someone as having epilepsy. So it requires either multiple seizures or separated at least by 24 hours without a known trigger or cause and continued in the future. And that, can take on many different forms and have many different causes, but that is what starts to lead a patient down the direction of the diagnosis of epilepsy.
So Cheatham, we, when it comes to, after we've got a reasonable diagnosis or reasonably firm diagnosis, where do we go from there? I think medication tends to be our sort of first line of defense here.
So once the epilepsy diagnosis is established, of course, the treatment options are available. So I think that one of the maybe misconception about the epilepsy is deemed to be not treatable, disabling. But in fact, that even though the most commonly seen chronic neurological condition in children is treatable. And in fact, that 70% of the children diagnosed with epilepsy responds to medication treatment. So the medication is usually the first line for the treatments. And of course, now that we have a number of different medications available compared to 10 years ago, even 20 years ago, even 5 years ago, I will say. And these medications, some of them have a completely novel mechanism of action. And some of them have a similar mechanism of action, but different benefits and side effect profiles. So always when we choose a medication, we look at the seizure types, we look at the patient's age, coexisting medical problems based on the metabolism of the drug that can be used for the treatment of seizures. If the child is on another medication, whether it's gonna the interaction between the anti-epileptic medication of choice. So a number of factors play a role, and age I want to underline the age factor, because some of the medications have been shown that actually they're have more adverse effect when used for the similar seizure treatment compared to the older age group. So as a child neurologist and epileptologist, always we look at all the clinical features in addition to the features on EEG and seizures, decide on the medication treatment. If medication treatment fails, and I will summarize it, if you use the one medication, as I said, that the chance for seizure freedom is 70%. If the medication fails to control the seizure, and if we try to use a second medication, the chance actually decreased to 30%. If we use in the failure of the second medication, the chance to really achieve the seizure freedom is 3%. So often that we remember these facts that, to navigate and what will be the next step if the second medication fails, what should we do next? And those are the patients we start thinking about the other alternative treatment options, including maybe dietary treatment options, surgery treatment options, even though the patient may not be seizure free, but the goal always is to improve the quality of life, whatever treatment option we choose.
Mm-hmm. And we're going to get to the surgical interventions there with Caitlin here in just a minute. But Danielle, I think in the past also the conception was that medications, if they controlled the seizures, left the child groggy, sort of zombie-like, and really knocked them out. Is that necessarily the case anymore with these newer medications?
No, it's not. And I think that that's an important thing to highlight. Part of our decision-making about picking a first and a second line treatment is carefully recognizing, and when possible, giving kids a specific diagnosis of what type of epilepsy they have, whether that's based on the EEG, the age of onset, the other comorbid neurological issues they may have, and genetic and imaging testing. That may guide us to make the best first choice for a first seizure medication. Many of our newer meds are extremely well tolerated, are available in kid-friendly forms like chewable tablets or liquid medications. And one of the things I sort of point out to parents when I go through a history with them at the beginning is that some of our medicines have, well, all medicines have side effects potentially. Some of our medicines have side effects that we can use to our advantage, like helping with headache, which is very common in children with epilepsy, or being neutral and not sedating, or for kids that maybe have very difficult time falling asleep, like some of our children with autism, a medicine timed correctly at bedtime that may help with that. So again, we want to emphasize to parents that we are trying to look at the whole child and all of the issues that they're confronted with, including their epilepsy diagnosis, and pick a medicine that's likely to work for their epilepsy type, as well as likely to leave the child in their best possible self when we control seizures. And in the event we have a potential but not desired side effect, that families feel comfortable coming to us and letting us know so that we can decide that maybe the seizures are better, but we need to pick a different medicine because they're too sleepy or have stomach upset or some of the other, infrequent but real potential side effects from our medicine.
So Caitlin, when is it after they've failed all of these or they don't tolerate it that they may turn to a surgical alternative? How do you make the decision that it's time to consider that seriously?
Right. As Cheatham outlined, it's really appropriate and advantageous for the patient to start beginning to think about alternatives once they have failed that second medication. Because as she indicated, you have a 3% chance of helping a child with a third medication versus a much higher percentage with potentially other maneuvers, some of which might be invasive and some of which may not. And so once a child has failed two appropriate medications, it's time to start looking more specifically at other alternatives. And, you know, it's often a difficult emotional and mental hurdle to approach from a parental standpoint. But that's why, you know, we work as a team to help, as Danielle said, approach these children and families as a whole and help them to understand exactly what Danielle just said, that the goal is maximizing quality of life for these patients. And it's really wonderful in the 75% of patients that can achieve that with medications. That's fantastic. But it shouldn't be seen as necessarily a riskier or a less safe direction to be going towards surgery. And that's a really important thing to understand, that if seizures continue unabated, they are continually affecting that area of the brain every time that child has a seizure. And then the longer those go on, the larger the network, the bigger the recruited area of involvement. And so that's why parents start to see over time real cognitive changes in the setting of untreated or inadequately controlled seizures that start to affect other quote unquote normal areas of the brain, right, that maybe weren't initially involved in this network. And so, you know, that's when we need to start shifting the fulcrum towards thinking about other options, that through the use of interventions, which we can get into more details, you know, as you'd like, we're actually using those maneuvers to protect the remaining brain. So it actually is the safer option for patients in order to protect the remainder of the brain's development, cognitive potential, et cetera.
And I think you sort of alluded to, it's an important point that also needs to be made or driven home, is that if you can identify a discrete focus that's the source of the seizures, taking that out, that's not normal brain. That actually improves the function of the rest of the brain.
Exactly. Yeah. You know, it's so there are two large approaches towards that. One is if you can identify the area of a seizure onset, right? So the term would be the seizure onset zone. It may be one, it may be multiple. If you can identify that one or multiple areas or network, you can either remove it if it is safe to do so, meaning it's in an area of what we would call non-eloquent brain, not being utilized for other functions, or you can disconnect it from talking to the rest of the brain. And those are kind of the two big categories of what we would call open approaches towards stopping or at least decreasing seizures. And exactly as you're indicating, and this is an important part of the discussion as we're walking parents and families through this process, that that area, even though it seems incomprehensible when discussing altering their child's brain structures, that you're not altering the normal portions. You're just simply stopping the abnormal parts from talking to the normal parts so that the rest of the normal brain can go about its daily business better and not be constantly interrupted. And these children can then therefore develop better.
Right, an important way to think of that. Tristan, you mentioned before that a very significant proportion of epilepsy has some sort of a genetic basis. And in the past, we pretty much had to turn to medication, surgery, other things. But now with precision medicine and identifying some of these genetic defects, there may be actually ways to get at that genetic defect. This sounds almost science fiction like. Tell me about that.
Yeah, it's exciting times. Knowing the gene responsible for a given epilepsy is incredibly powerful. And it has us thinking about patients in completely different ways. And it's already led to improvements in treatment. My favorite example is there are babies, newborns who suffer from certain genetic epilepsies in which using carbamazepine, a medication that is not typically used in the nursery, leads sort of immediately to seizure cessation in many cases. And whereas the medications that are typically used in babies with seizures don't work as well. And that's a good example of sort of immediate change in practice, sort of like best practices. But the real promise of identifying the genes is the idea that we can somehow reverse that genetic cause and treat not just the seizures, but the underlying condition with all of its comorbidities. And this is, as you said, it's like science fiction, but it's being done now. There are studies recruiting now for genetic manipulations of a gene called SCN1A that causes Dravet Syndrome. And so that's a good example of a condition that results often from too little production from that particular gene because of one bad copy. And the approach that's being taken is to try to increase the amount of that gene product being made. And the study's recruiting now. So this is kind of where we are. And I would say even beyond that, identifying the genes allows us to model epilepsy in systems that allow us to ask questions about how epilepsy works in ways that we haven't been able to before. And that has the potential to impact not just people who have these particular genetic causes for their epilepsy, but epilepsy across the board, in the future.
Interesting. So Danielle, let's go from the science fiction frontier there that Tristan's talking about to what seems like a much more low-tech approach. There are actually some dietary interventions that may be able to help control epilepsy in children?
Yes. So from ancient times, there's documented history of fasting improving seizures in patients with epilepsy. Sort of early in the 20th century, ketogenic diet was put forth both for management of diabetes prior to the use of insulin, but specifically for helping patients with intractable epilepsy. And anywhere from 30 to 50% of patients who are treated on a ketogenic diet may experience significant improvement in their seizure control.
This is basically a kind of a modified Atkins diet or a strict Atkins diet?
So in the traditional form, this is a Atkins diet on steroids. So this is an extremely restricted diet where the majority of calories are from fat. Carbohydrates are extremely restricted to a very small amount, and a little bit of protein is allowed to account for the needs for growth. Other more liberal diets have been tried, including a modified Atkins diet, which is about a quarter to a fifth the amount of fat as in a traditional ketogenic diet. Even more liberal versions have been used where more carbohydrates are allowed, but low glycemic carbohydrates only, so not simple sugars. And all have been shown to improve seizure control. All do have side effects. So many families will come saying, I don't want medicine, I want a natural treatment. And, we're very clear to emphasize this is not a natural treatment. This is nothing like a paleo diet or a healthy Mediterranean diet or what most people in the United States are eating. It comes with potential side effects. Being in ketosis can make you feel sluggish unless we manage things like your acidosis. It can put your bone health at risk, again, unless we manage acidosis and supplement you appropriately. And it can result in kidney stones. So I've seen patients sort of self-try modified Atkins at home and develop a kidney stone and then come to me, to be managed appropriately. So it is important that a registered dietitian who's knowledgeable in the ketogenic diet is involved in every step of the way. Traditional keto diet involves a lot more structure and education, and we've found for it to be successful, putting that effort in up front before you actually start patients makes them successful and able to maintain the diet. When it's done sort of hurriedly and without the appropriate education, families often feel overwhelmed and give up. And that's too bad, because the patients that we tend to see are in that 30% that don't respond to two meds, and usually either have certain genetic types of epilepsy or syndromic epilepsy that's probably genetic, but we don't yet know why. who have a high comorbid burden from their seizures, resulting in regression and loss of skills. And so sabotaging the diet before it's even started, it would be very bad, because this may be their one chance for seizure control in the event that they've been found not to be a good candidate for surgery. So, yeah.
So how realistic, though, is it that you can keep a child away from birthday cake, cupcakes, all the candy, all the stuff that kids love to eat?
So you don't necessarily have to keep them away. You just have to give an alternative. And there is a huge network of families and recipe alternatives for very visually appealing and also very tasty options on diet for kids who eat orally. For kids who have other delays that prevent them from eating an age-appropriate diet or require tube feeding, it may be more straightforward. But, you know, we advocate with schools for appropriate aids to make sure younger kids don't get into their neighbors' kids. And, you know, once you get over the initial sort of understanding for caregivers, staff at school, grandparents who want to sneak a cookie, it's actually pretty straightforward. And, you know, in keeping, I think, with our American culture where people have lots of food allergies and restrictions, and parents make it work when they see the improvement in their kids' lives from the diet.
I'm having trouble picturing my childhood without ice cream, but
there's actually a lot of keto ice creams available, just without the sugar.
Really? Wow. Okay. Terrific. I'm not going to try them, but I'm glad they're out there. Cheatham, tell me, we talked about, in terms of helping with the diagnosis, video EEG, but we've got so many toys these days, high-tech ways of looking at the brain. Is there a role for different types of MRIs and some of the other things that we're now hearing about, in terms of really being able to zero in on different types, or where the epilepsy, where the epileptic seizures are originating in the brain?
So in children, basically identifying the origin of the seizure or localize the origin of seizure is very challenging. The challenging in the, you know, many grounds, not necessarily only based on the clinical manifestation, sometimes might be misleading us that whether or not this is a focal seizure starting from the one origin in the brain or generalized seizure. But also EEG findings may not be localizing as much. We may not be able to see the activity. As Tristan mentioned, that it might be the deep-seated maybe area that we may not be able to really obtain the recording or information by the recording. And then we may rely on the imaging findings. But the story about imaging is also not I will say, that much helping us often. You know, nearly 50% of the children with especially focal epilepsy may not have any imaging abnormalities. So almost like that makes us so impaired to really to identify the origin of the seizure, to proceed for maybe even surgery treatment option if medication fails. So what we do, we look at the different imaging modalities. I think one of the advances in the field of pediatric epilepsy or epilepsy in general is the really in imaging. And advances in the imaging technology, imaging quality, and also introduction of the various new functional imaging modalities really instrumental for us to make the case. Almost like I always see and tell that these are the piece of puzzles. So in order to get a bigger picture or the full picture, we have to look at every piece of the information presented to us in, you know, from the imaging studies, from EEG, from clinical features, from examination, etc. Then we make the really entire epilepsy diagnosis as a whole to proceed for the proper treatment. Mm-hmm. So coming back to your questions and what are the tools we have, we are fortunate at Columbia University Medical Center that we have lots of various different up-to-date imaging studies available. And once we see that EEG is not really helping, seizures are similar stereotype, and we believe that there are focal seizures, then we proceed for maybe the high resolution imaging first. Then we look at the functional imaging, and such as PET imaging, Spect imaging. They are certainly not new in the field, but now that we are analyzing this data available from the imaging, and then we may overlay them under one model, and then we may analyze them quantitatively, just looking at the specific area of interest, measuring the activity, metabolic changes, blood flow changes. And then we come to the conclusion. If the child is a surgery candidate, then we can really refer the patient for surgery treatment. Or we may turn the page and then look at the alternative treatment options, new medications or dietary treatment options, or sometimes the palliative treatment options that our surgery colleagues and Caitlin always help us just to find out whether or not maybe a resective surgery, but other maybe surgical interventions, device implantation will be beneficial for seizure control.
And Caitlin, it sounds like a lot of this technology has really helped you in figuring out what is appropriate surgery, where you operate, and so forth. And I apologize, I didn't mean to make light of it by calling them toys. These are very, very important. This is very important technology. Tell me how you're putting that to use, because I remember years ago being in the operating room with your colleague, with Dr. Feldman, or Feldstein. And it seemed like the main way you had to really open the skull and lay some electrodes literally on the surface of the brain to try to figure out where the seizures were coming from. That's not always necessary anymore?
No, it is still a highly utilized, highly successful, and very useful tool for sure. But as with everything else, a lot of the advances that have been made over the last decade or two have been to create less invasive options and to advance the non-invasive workup. And so by that, as Cheatham laid out, yes, it is extremely important. What do the child's seizures look like? Yes, it's very important to then combine that with, do we see a correlate on MRI? But then you have to put together, well, does what we're seeing on MRI relate to, does it seem like that's where the seizures are coming from? So then we reach towards, as Cheetah mentioned, PET imaging. What that means is that tells us how the brain is using energy and how it's metabolizing energy. So areas of the brain that are seizing a lot will essentially become a bit scarred. They become injured, and so they're not going to metabolize as well. And so what that does is it creates a bit of a cold area on a PET scan. So you give a patient a metabolite, and then you're looking at how the structure of the brain is utilizing those metabolites. And where you see these colder areas are potential areas that have been affected by seizures. So that's another piece that we then overlay. And then another, as Cheetah mentioned, is Spect. This is another metabolic test, but it looks at the opposite. It looks at during a seizure, where does the blood flow go? Totally different way of looking how the brain's using sources of energy. And so then it can say, because sometimes the MRI looks stone cold normal, but based on a patient's stereotype seizures over and over that tell you this must be coming from, for example, the frontal lesion or region or the temporal region. That Spect scan can confirm that for you. Even if the MRI doesn't show you a structural lesion, it can say, well, yeah, all the blood flow is being diverted to this one area. So that's another piece you can lay on top. One of the more recent advances is called Meg Magnetoencephalography. This is putting together MRI and EEG, and it utilizes these what we call dipoles a little bit differently in helping us to identify deeper foci that might not be visible via EEG or MRI alone. So there's another layer. And so what we do is we stack all of these pieces of information on top of one another an important piece of that stack is our conversation together and just sitting together in a room full of 30 people and using the horsepower of that experience and working together, which is one of the most important pieces of this. Neuropsychology is a huge part. So that tells us how to meet this child where they are. What is this child's function? What are their current deficits? How do those deficits maybe relate to where the seizures are coming from? But even more importantly, if we disrupt an area of where the seizures are coming from, what might that do or not do to a child's degree of function and quality of life? And all those pieces go together every week into these types of conversations. And so that's how
right. So just identifying where the seizures come from is not necessarily enough unless you figure out whether that's an area that's a vital or an important, as you put it before, eloquent part of the area of the brain, because taking that away, you may do as much damage as good by doing that.
Exactly. Exactly.
Can I add one more thing that I think Keith mentioned, that, this is very important to remember that in the old days, if the MRI is normal with a focal epilepsy, always that deemed to be that is not going to be treatable surgically. Right. This concept has changed now. So we know that. That's why all other additional diagnostic testing is critical. Just even though MRI is normal, we may identify the seizure focus, and then those children can get epilepsy surgery and be seizure-free. We have so many examples here in our institution that MRI was always, normal and never been referred for the further evaluation. But then later, somehow that they find their way, or they refer to us, or we find out when they arrive to emergency room, then even though MRI was negative or was normal, then they got epilepsy surgery. But again, that's not based on the only one piece of information, number of information that we actually referred as a comprehensive care. And that's why that, as Caitlin mentioned, that group of specialists from the surgery, from neuropsychology, from neurology, from pediatrics, from pediatric neurology, radiology, get together to discuss those cases.
And that's why it's so important to be at a center like Columbia, where you have all of these different specialists that can weigh in or help out with the diagnosis and help tease apart what would be the appropriate treatment for a particular child.
Yeah, no, it's essential. One piece of information in isolation in epilepsy is absolutely, not. It's fairly useless. One thing that I just wanted to also mention, to take it one step further, you mentioned, the concept of grids and strips and laying these large structures over a very large surface of open brain to help, figure out the seizure onset zones when non-invasive methods still don't yield enough information to guide us towards a safe surgery. A wonderful modality that has seen a renaissance in the last decade or two has been stereo EEG, and it's important to touch upon that. It's a tool that is used beautifully by everyone on this call and by the Columbia group specifically. And it's the development of the use of very small electrodes, just a couple of millimeters in width, to achieve that same task that we used to require this big open exposure of a very large brain surface to then map it and record off of it. And instead, there's now a robotic interface that makes very small little openings in the skin at predetermined areas of necessary investigation. So we create a hypothesis based on all those pieces of data we just discussed. And we talk about where we think it might be coming from, what areas we need to sample and map. And then the robot guides the openings in the skin and bone to each of those areas and places a depth electrode at each place, guided, of course, by a surgeon or two. And then we record off of those. And they are so small that they can actually all be removed at the bedside, and the patient goes home the next day after that investigative procedure. So, really interesting ways that this is just taken leaps and bounds for the patient's quality of life and experience in going through this process.
That's just remarkable. Tristan, I'm really fascinated by the ability here to do something get at the cause, to get at genetic causes. And one of the things that I know I've seen here is an interesting, it's a term for, I guess, a drug that, or an intervention that sounds a little funny, antisense oligonucleotides. What does that do when you're dealing with, say, a genetic, where you're trying to do a genetic intervention, as it were, on a child with epilepsy?
Yeah, so for many epilepsy, so for many of the genes that are associated with epilepsy, the understanding the cause in terms of whether it's too little of a product being made from a copy of the gene, or in the case of, in particular, of certain genes that code for ion channels, it could be that the ion channel that's being made has extra excitability that it should not have, and that's called a gain of function mutation. Understanding those aspects of the genetic changes underlying epilepsy allows for different approaches to trying to get at the cause. And one approach that is gaining traction in a number of different trials, and I mentioned one earlier for Dravet Syndrome, is manipulating what happens with the messages coming from the genes, either telling the body to destroy the messages because they're bad, or potentially to make more of what those messages encode for. And so there are different approaches for different conditions based on the mechanism, but there are trials looking at antisense oligonucleotide therapy for a gene called KCNT1. There's SCN1A, as I mentioned earlier. There are also, for ion channels, in addition to the oligonucleotide therapy, there are small molecules that are being developed to sort of target the gene products directly. And we're getting involved in some of those studies. And there are many coming down the pipeline. So it's a little bit, so 2 years ago at the American Epilepsy Society meeting, there were a number of platforms demonstrating trials that were sort of in the planning stages. And we're at the point now where the floodgates are opening, and there's a huge push to have these molecules developed, and so it's very exciting, and it's going to change the way that we address many of the patients that we've been talking about, the ones that are not responding to the first two medications, who may not be epilepsy surgery candidates, who even ketogenic diet may not be working for. This provides a whole new approach. And importantly, you've heard it again and again from multiple people on the call. It's really, I like to say I like to treat seizures, but I really like to treat children with epilepsy even more. And I think that's really, people keep bringing up this issue of quality of life, and really that's what it's about. And everybody who is on the call is thinking about not just, well, what can we do about the seizures? It's how can we attack the seizures while not making the kid too sleepy to do the things that we want them to do, and how can we also get them the help that they need, because many of our patients also require IEPs for school and help with lots of different comorbidities. And so precision medicine falls right within all of the other things that people are talking about on the call, in terms of having as its focus not just the seizures, but really the idea of treating the condition itself and improving the quality of life, which I think is a big deal.
So the frontier here really is figuring out the molecular basis for seizures, which may be different for all these different epilepsies.
Yeah, you know, so now you're getting near and dear into my research heart. Sort of like, you know, one question is, well, don't they all sort of converge at some point? And we could have a long, you know, conversation offline about that. But yeah, no, I think there are two schools of thought. You know, one school of thought is, well, let's figure out how it works. And the other school of thought is, we have the gene, let's just fix it, you know? And so I think there's this competing aspects in the research world that has been interesting to play out. And I think ultimately it's a false dichotomy and we have to do both, but.
Right, exactly.
Can I add one more thing that I want, you know, Tristan, you know, I will start, but I want you to maybe take it on that in the past that when we make the genetic diagnosis always that, you know, we shy away and then we used to think that, oh, maybe that nothing is going to work and, you know, seizures are not going to really respond. But now that actually advances in the field that even knowing the underlying genetic condition, helping us for the medication choices. Maybe that, you know, Tristan, you have more experience with that. Maybe that, you know, you can guide us that, you know, how we do in the practice.
Yes, I think you're exactly right. Initially, I think when genetic testing became available, it was sort of, I think a lot of this was coming from providers. We were worried, okay, we get a genetic diagnosis and it's sort of like, you know, a loss of hope, but actually it's turned out to be quite the opposite. And I think that, you know, at one level, it's about families connecting with each other. Families of children with rare genetic disorders learn more from each other than they do from their doctors, even if their doctors are well schooled on that particular condition. And it's just about people being able to communicate with other people who are having a shared experience. And so that by itself, even if there were no treatment implications at all, that by itself would be huge in terms, again, of quality of life for the families involved. And the truth is that there are clinical implications and we're sort of uncovering them all the time. And they, you know, they're not all trials that are coming. Like I said, some of these are really meaningful things that involve, you know, best practices. Giving carbamazepine to babies with KCNQ2 genetic epilepsy. That's big. If you stop seizures when they're happening in the nursery, we don't know, you know, the consequences of recurrent seizures on developing baby's brain. We think that certainly contributes to their developmental outcomes. And so
neuroprotection in a sense.
Yeah, and things like you know, knowing what treatments to avoid for certain conditions. We are only sort of scratching the surface of kind of a lot of low-hanging fruit, just in terms of people putting together their experiences with a lot of these rare epilepsies and saying, oh, you know, I have a patient who has that exact same mutation, and have you tried this medication? Because we really found that it worked. I mean, in fact, I share some patients with Danielle who respond very well to ketogenic diet, and they have a disorder that is like a class of genetic mutations that cause a certain metabolic condition. There's no reason to think a priori that ketogenic diet would work particularly well for them, but we found that it did, and it's been reported by other people too. And so that's how you sort of, when I say that the knowing the gene is very powerful because we're thinking about patients in a different way, this is what I mean. Before, we wouldn't necessarily be putting certain patients together and thinking about them as having the same condition before.
I would just add, if you don't mind, I think that, we've talked about the highest tech interventions, and how much this field has changed, but, this is still neurology. And, you know, going back to neurology, you know, 20, 30, 40, 50 years ago, that physical exam, the history, and being very methodical and detailed about understanding what's going on with your patient. You know, Tristan mentioned SCN1A and the trials that are going on, you know, at a fundamental genetic level. But that's the genetic abnormality that underpins a disorder called Dravet Syndrome, which was really a well-described syndrome looking at this group of children that didn't respond to seizure meds the way they should, that had these very unusual features, that went on to sometimes die suddenly and unexpectedly. And from there, learning based on, they do really well with certain meds and sodium channel meds, which this SCN1 mutation is, they do poorly with, helped lead us. And I think what we're realizing now is that that neurology of what we do is not lost. And as we start to uncover so many genetic disorders that I can't remember them all, I'm sure Tristan can, being a good clinician and understanding what's wrong with your patient helps then us identify new things. And I think that's really exciting about neurology, that we're both embracing the history of what it means to be a neurologist, and particularly a child neurologist for kids that don't talk and can't help you understand what's wrong with them, and embracing the technology. It's very fun.
It's the convergence of precision medicine and genetics with old-fashioned empiricism, in a sense. Danielle, as long as I've got you there, because I know we're running out of time, and I want to get a little bit a take-home nugget of wisdom from each of you. But let me just ask you a couple of the quick questions that came in here, and I think I know. One of the answers is one of the questions is, what is the drug of choice for seizures in children? And that all depends. But what about one of the things that got a lot of attention for a while there, cannabinoids, CBD, THC. How do you feel about that? And is there a role for that in some children with epilepsy?
So I'm going to take a little bit of that, and then I'm going to give it to Tristan, because I think he was involved with some studies, you know, even during his training. But, you know, I think there's convincing evidence that CBD oil, particularly in a refined product, which we now have available by prescription called Epidiolex, can be very effective in specific epilepsy syndromes, often genetic, and often very catastrophic early epilepsies. And I think that there's likely to be ongoing and continued research to see how it helps, given that we have this subset of patients. And, you know, we've had patients that it's worked very well for, and other patients that it's not. The one thing I tell families is, it's always, well, you know, I want something natural. I don't want another medicine. This is another medicine, whether you get it from a consortium in another state or whether you get it by prescription. And it comes with side effects, and it comes with risk and benefits, and it interacts with many of the other medicines that we use. And so it's important to do it thoughtfully and in collaboration with your doctor. And it's in those situations that, you know, it can be a very powerful tool in our toolkit.
Yeah. So I want to be respectful of people's time here. And what I always like to do at the end of our webinars here is ask each of our panelists for a brief, that being the operative word here, nugget of wisdom, a little pearl, a take-home lesson that we want our viewers to remember from this. And Caitlin, I'm going to start with you.
Yeah, I think that the most important thing, you know, to take home from this, and I think what I love about epilepsy and what we've heard as a resounding theme, is that there's so much hope and there's so much innovation. And I think that families should really hear that there is what you're hearing as a tremendous history and a tremendous body of experience, but there's also a lot of momentum forward as well. We have a lot of tools in the toolbox to help our patients. We do it as a team, and that's why I love doing what I do in this realm. And I think that that's what families and practitioners that are trying to help their patients should take away from this.
Tristan, what do you want people to remember?
Epilepsy management, epilepsy care is not one size fits all. And so to sort of get at the question that you got in the feed, it's got to be tailored, and whether that's, you know, through precision medicine approaches or through all of the things that you heard other people talk about, figuring out where seizures are coming from. Okay, you said be brief, so I'm gonna stop. So one size fits all is not the approach. Tailored method.
Fair enough. Thank you. Danielle, what do you want people to take home from this?
I think for practitioners who are seeing kids presenting initially, that this shouldn't be presented as sort of an end of the world diagnosis. You know, we focused on the 30% that don't do well, but most kids do well. And most kids do well whether they have other comorbid issues or not. And, you know, presenting families with hope and arming them to speak up if they don't feel like their child is doing well or having other issues, because that shouldn't be accepted. And that's not what we expect for our patients with epilepsy.
Cheatham, as the chief, you get the last word.
So I will say that epilepsy care is not the seizure care. Epilepsy care is that how we can improve the quality of life for the child. So what it means that if we use the medication, if the medication fails, there are alternative options. There are alternative treatment options available. However, it requires a comprehensive care. So I think that we should not give up. Once the medication is failing, we should really turn the page and look at that, what else we can do and what other options available for the child, not for the seizure control. We may not achieve the seizure freedom, but even if we achieve 20, 30% seizure reduction, that may actually impact on the quality of life for that child. So we have to remember the fact the goal is not seizure freedom. Goal is how we can really improve the quality of life, even by seizure reduction of the seizures.
Thank you. And my little nugget is to essentially echo what has been said a little bit earlier is there's a lot of hope now. There's a lot of research. We've got a lot of tools in the toolbox. And also, I think that points to the importance of being at a center where all of these tools, all of this expertise can be brought to bear on a child with epilepsy, particularly if they're not doing well, because it is about quality of life, helping them develop normally, education, and so forth. So that is a very important, I think, message to take home here. I want to thank all of our panelists for just a tremendous evening and so much great information tonight. A reminder that this has been recorded. It will be on the YouTube channel. What did I call it? Columbia Children's Health on YouTube. And there will also be a summary of the key points from tonight be sent out to all our registrants. Again, thank you for being with us and have a great evening, and please wear a mask.